Welcome to Modern Management of the Older Adult, brought to you by the Institute of Clinical Excellence.
Hey everybody, welcome to the Older Adult Live Podcast. Today you will have my husband, this is Corey Blankenship, and then me, Shelby Blankenship. I'm one of your TAs and a fellow physical therapist that owns Southern Grit. And we are going to be talking about how you can handle a worst case scenario and what best practices to do that with. So as we know, CPR training is required for pretty much every healthcare professional. And so what we're going to talk about is a little bit of the ins and outs of what is very appropriate for us to do, what are some pitfalls that my husband has seen on the job, and how we can optimize that, and some of the aftermath of having to do CPR or a situation like that. So let me just interview my husband real quick, and I'm going to ask you, when it comes to CPR, what are things that as healthcare professionals that we need to know for our jobs?
One of the things you have to remember is that when it comes to CPR, we really want what they call like high quality CPR. And in high quality CPR, you are minimizing interruptions as much as possible. So kind of the standard for years has been 30 compressions, 2 breaths. Well, that adds up to a lot of pauses and a lot of interruptions in CPR. So what we see a lot of time in my profession is it's more effective to do continuous compressions rather than stopping every 30 compressions to check to see if somebody's breathing. Another thing to remember is you don't want to do CPR if somebody has a heartbeat. And I know that sounds kind of silly to say, but we see that very often where chest compressions are started on somebody who does have a pulse, and it's not necessary.
Right. Now, when somebody's trying to check for a pulse, what are areas where they tend to mess up and they assume they don't feel that heartbeat?
Well, there's 2 things that people do. They either don't check the right area, so you want to be checking right in here, or if you're checking, with your own hand and you're using your index and middle finger, you can feel your own pulse sometimes, and that can give you a false reading. So using the middle and ring finger is a little more effective to do that.
A little bit less sensitive.
Yeah. If you're having trouble feeling the pulse in here, also feeling like on the inside of the groin is another really effective place to check for one.
Okay, very good. What about like for some of our, like we primarily deal with a lot of older adults, and sometimes, they might have like extra adipose tissue. So would you recommend going for here, or would you recommend going for radial, femoral? What would be the best practices for that?
Here first, because that's going to be stronger than a radial. After that is when I would go femoral, but the closer to the trunk is where you're going to get the strongest pulse, and that's going to give you the best indication.
Okay. So when it comes to CPR, it's not just the compressions, but I know it also, the breathing aspect. What would you recommend for somebody who is like a one person doing CPR? What, obviously we want to focus mostly on doing the compressions. If a second person comes, what is their job?
So the first step is going to be that one person is going to call 911. You want to get other resources there as quickly as possible. But then, like we talked about, you're going into the uninterrupted CPR, continuous compressions. When you get somebody there, probably the most important thing, if it's just the 2 of you, is going to be taking turns and swapping out probably every 90 seconds or so. CPR is really exhausting if you're doing it well. It's 100 to 120 beats per minute is what you're shooting for. So after 90 seconds of it, you're going to be wiped out. And depending on what the EMS response time is, you may have 10 to 15 minutes before somebody else gets there. So between the 2 of you, swapping every 90 seconds so you're able to get back in and get back on good, strong compressions is going to be really important.
Okay. And then what about like the breathing aspect? Is that something we should completely ignore? Like what if we have extra items like you have with here? What should we do?
Yeah, so what I would really recommend is having one of these in your clinic or whatever setting you're in. This has a lot of names, a bag valve mask, BVM, or an ambu bag. These are great because it totally eliminates the need for that mouth-on-mouth compression, which is just kind of nasty. And honestly, I would never recommend doing But you also have the option to hook this up to oxygen. So if first responders arrive on scene, they can hook that to their oxygen tanks. That's going to supplement what you're doing. These are very effective. But knowing how to use this properly, you're not just going to slap it on somebody's mouth and squeeze it as hard as you can. You're going to use what's called a CE clamp. So make a C and an E with your fingers. With the C, you're holding around the mouthpiece. You're up at the head of the individual that you're working on, creating a tight seal around their mouth with that C, and then using the E shape of your fingers to grab underneath their chin and lift it up. So performing that jaw thrust maneuver to lift it up. If you have multiple people to help you, I would even recommend one person is just responsible for squeezing the bag. The other holds the bag on the side to get a good solid seal over the mouth, because that's a problem that we see a lot is, you're bagging somebody, but there's not a good seal, so the air's not going where it needs to go.
Right.
And then using the fingers to grab behind the jaw, lift it up and forward, so you're getting a good seal. Again, remember with this, you're not just cranking on it as hard as you can. You're going to squeeze it over a 3 to 5 second length of time, allow it to refill, and then you're giving one breath about every 5 seconds.
So this is going on simultaneously as the compressions?
Yes, this is going on while compressions are being performed.
Okay. And then what other items would you recommend like an outpatient clinic have besides an airbag, if anything?
So there's one thing you would need specific training to use this. This isn't just something you're going to learn how to use in a standard CPR class. But these are called eye gels, and some studies have shown that these are as effective as intubation, but it's much easier to perform. This has got a soft rubber head on it. There's lubrication in here, so you're going to lubricate the outside of this. Once you remove it from the package, it goes down into the person's throat, and this is called a supraglottic airway. So it's going to form a seal over the glottis with that soft rubber head, and then it can be actually attached to the bag right here if I take that mouthpiece off, and that's going to be much more effective because there's no leaking of air around the seal with the mouth.
Very cool. Now I'm guessing a lot of extra training to be able to do that,
Yes.
but very cool little extra bonus. Very nice. Now what about, like, obviously we deal with a lot of older adults, DNR versus not DNR. So a DNR is a do not resuscitate. Sometimes we have access to that information, sometimes we do not. What would you say if we do not have access, what do we do?
So if you don't have access to that information, then you have to start CPR on somebody if it's necessary. So if they're not breathing, they don't have a pulse. If you have that DNR, you're going to want to check to make sure, does it have a valid date on it, and is it signed by a doctor?
Okay.
When first responders arrive on scene, you have to have a physical copy of that DNR for them. So you can't just say, hey, this person has a DNR. You have to have it there for them, or they cannot follow that. And if that DNR is the only one you have, you can't give them alternate instructions. Does that make sense?
Yeah.
So I can't say he has a DNR, but if I'm not the family member or the power of attorney, I can't have you start compressions on somebody when their DNR says otherwise.
Okay. And then if, like, I know sometimes, like, when we go to do CPR, especially with older adults, that I'm going to call it crunching for lack of a better word, but the rib cage is a very traumatizing event.
Yes.
How would you describe it? I know you've been in that situation quite a few times.
It's something you have to prepare yourself for because it is a horrible sound and completely unnatural, but it's going to happen. And a lot of studies have shown that most of the time when chest compressions are performed, I think it's over 70% of the time there are rib fractures from the aftermath. So just be prepared, especially with older adults. That's probably something you're going to hear. And it's going to sound like you're pushing your hands down on a bag of pretzels. CPR is not what it looks like in television shows or movies. You never see people just pop back up from it and go back on with normal life. It is very violent, very traumatic. You may get a pulse back, but the likelihood of somebody regaining consciousness after doing that is very, very small. In 5 years, I've never seen that happen.
Okay. And then what if you suspect, like you finish CPR and then people are starting to come in to kind of help out, whether that's EMTs, firefighters, etc. What information is vital for us to instruct them on what's been going on? Where do we need to step back? Where do we need to still help? How can we be helpful?
Yeah, so whoever is in charge will give you instructions, and they'll either have their people come in and take over compressions, or they'll check with you and say, hey, I'm about to switch. We're going to go in 3, 2, 1 and switch. At that point, unless they ask you for your help, it's best to just stand back. The more information you have, the better. So was this a witnessed arrest where you saw the person go down? How long has the person been down? Approximately how long have you been doing compressions? If you used an AED, has it delivered a shock or anything like that? So the more of that information that you can give to give them a better picture, the better it's going to be.
Okay. And then as far as like the aftermath of a situation like this, obviously we already talked about like the sounds that can occur during, but what emotional waves should you expect for you to experience?
It's a heavy thing to do that. And so to go from that right back into like whatever you were doing before is kind of unrealistic to think of. So don't be surprised if you're a little like, especially the first time, you're a little thrown off by it, because that's normal and that's going to happen. I mean, having to crank on somebody's chest and hearing that crunching and the other things that go along with CPR, if you've seen them get shocked and jump up off the floor, like there's a lot to that.
Sure.
So it's a lot to unpackage.
Okay. As far as if you were in an outpatient setting where you have one person who's having to administer all of these items versus maybe like in a hospital where you have like a big flood of people coming to help. Mm-hmm. If you're just a single person trying to handle this situation, what would be first things to do and then kind of the order of that versus if it was like
most AEDs have sensors now. They call it a puck, and it goes right over the sternum, and it'll give you feedback as far as like compress faster, compress harder, good compressions, and it just gives you a really good idea of what you're doing. At that point, you can even follow the instructions of it. It'll tell you to just keep doing compressions. It'll tell you to stop if a shock is required or not required. So that can take a lot of the guesswork out of it. If you've got multiple people, one person needs to take charge and give instructions of get the AED, let whoever's going to start compressions know they're starting compressions, and then almost act like a pit crew chief is the way that we were taught in EMT school, is that you assign somebody to the breathing aspect of it, one person to compressions, one person's calling for help, and then you're making sure that people swap out as is appropriate so that you can continue high quality CPR until further help arrives.
Okay. Now, as far as CPR aftermath, going back to that, I know like wrist mobility
yes.
is something that not only is required really for CPR, but can get very tender afterwards.
Yes.
Any other like musculoskeletal things like we need to be aware of? I know obviously like kind of locking out elbows. What else?
Locking elbows and putting your full body weight into it. Because remember, you're compressing the chest like, I think it's like a third of the depth of the chest or something like that. So you're pushing in a long ways and you want as much weight behind it as you can. Going like this, I have very limited wrist mobility, so I can be sore for a while after doing that. Sometimes you can get one hand on there and the other hand behind it, or one hand on the wrist to support, and then just put your body weight into it. It's not uncommon for your lower back to start getting sore doing that, especially if you have to do a lot of compressions before somebody can take over. So those are just things to be aware of and things that it's not abnormal to see.
Any other tips, tricks that we should know?
So when it comes to the compressions that you're doing, a problem that we see a lot is that people don't allow full recoil of the chest when you do that compression. So if I'm pushing all the way down and then only letting up a little bit of that and pressing again, it's not allowing as much blood to pump through the body and getting that oxygenated blood to the organs. So allow for full recoil in between each compression that you do. And figure out how you want to count those compressions too. Like for a long time, Another One Bites the Dust
Yeah.
was kind of like the standard go-to for that. I think a study recently found that people were going too fast because they'd speed that song up in their head. Baby Shark is another one that a lot of people are familiar with. They taught us that in EMT school, and that goes through my head every time I do chest compressions. It's just Baby Shark.
So I think of The Office. And I get it. Awesome. Well, thank you so much. Is there anything else?
That's
okay,
it.
Great. Well, if you are coming to join our older adult crew, we've got L1 popping up May 19th. L2 is popping up May 15th. And then we've got some lives popping in May 31st. We're going to be in Greenville. I think that's going to be me and Jeff. And then June 7th, we're going to be in Pennsylvania. So hopefully we'll check y'all there and hope this was helpful for you. Y'all have a great day. Thanks.
Thank you for listening to the MMOA podcast. If you found this helpful, please share with someone that could benefit. And if you're looking for more practical content to help you better serve older adults, head over to www.mmoa.online, where you can learn more about our free resources, our community, continuing education courses, and our certification. Once again, that's www.mmoa.online. Thanks for listening.